Well, welcome to this special episode of The Dental Guys in collaboration with the Academy of Osseointegration. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy, and we're live here in Seattle at the annual meeting, the 40th anniversary annual meeting, no small thing, in one of our favorite cities to get to meet. So excited to be here, and we're excited to bring a couple of pretty special people this evening, some that we've talked to before, and some new folks as well. And so we got two doctors here, Dr. Georgios Romanos and also Dr. Stanford. And so thank you, first of all, for being with us tonight. We're looking forward to talking with you guys.
Sure. Thank you.
Yeah, it'll be a good time. And your topic, I really just want to maybe expand on some of the things you've already been speaking about today. And it sounds like, and I don't know if this was a topic that you chose or a topic that was assigned to you. Was it assigned? Okay. But it seems like it was a pretty appropriate topic, though, because I know, especially Dr. Romanos, you've done a lot of research on the one abutment concept. And so let's talk about that. Let's talk about the idea of one abutment, one time, and what does that mean? And maybe how did you arrive at where you are? And then Dr. Stanford, I want to hear from you as well on, maybe some good and some bad about those ideas.
Thank you for having me here. In the reality, in research, many things occur by coincidence. I was trained in periodontology and then in prosthodontics in Germany. And then I moved to oral surgery department. And I have learned in prosthodontics at that time in 90s that before the time of the implants, we have to parallelize teeth in order to make the fixed restorations in the maxilla or the mandible. And all of these teeth, they are relatively conical. Otherwise, you have undercuts. People who have done this for years, they know that. When I was in Frankfurt in Germany, I got the assignment by my chair to go to Malaysia and to do research in monkeys. In monkeys, you have complete different behavior. It's not like the dogs. First of all, you cannot brush the teeth, the implants, etc. You have plaque accumulation. I started placing implants with platform switching at the time, and also some of the implants were placed epicrestally or subcrestally, but I didn't have a lot of space because the monkeys were macaca fascicularis. So I had to deal with small dimensions. And 1 millimeter plays a very important role in monkeys. So later on, parallel also this time with Frankfurt, with my time as a resident and then as an associate professor, in this period, I had the possibility to treat plenty of patients. And I came to the concept to place the implant subcrestally, 1, sometimes 2 millimeters. I had one patient 29 years ago, which I show today, who actually had very soft bone in the posterior mandible, and I placed the implant 4 millimeters subcrestally. But luckily, this implant system was with platform switching. So I placed the abutment later on without to remove the bone, the crest of the bone around the implant, and the abutment I selected, like in my other studies, was a conical abutment, very narrow abutment. And I was able to parallelize the implants together. So I came by this, using these coincidences, if you want, having the experience from biology, from humans, and then with animals, and looking also in the literature very early on, and I was lucky for this. I'm talking about 93 to 96, to load implants immediately after surgery with the same abutments, without to remove the abutments, and this is what I showed today with multiple cases, series, and also clinical trials. And the confirmation came later on, independent if the soft tissue was thin or thick in aesthetic areas or in posterior maxilla, posterior mandible. As a conclusion, placing implants subcrestally, anytime you open a flap, you remove bone. Automatically, the biology removes the bone. You don't need to grind the bone. If you grind the bone because you have issues with the interocclusal distance, you must place the implant subcrestally because the remodeling occurs and the implants will be exposed in the oral cavity. Compared to my other colleagues who are surgeons or restorative dentists, my hands, I do both. And I have the possibility to manage maybe the tissue better and also placing the implants in correct position to be able to manipulate the peri-implant mucosa and the peri-implant bone better than others. So I think I answered your question specifically, how did I come to this? And I use it for now close to 30 years.
So that, when you mentioned subcrestal placement, it makes me want to detour just a moment into something that it's not exactly on topic, but I think it will make both of you happy to talk about. So we have heard a lot in the last even day about what matters the most? We always kind of come back to this idea of, is it the surface? Is it the surgical placement? Is it how much does the biology play a role? And how much is it the implant design? And I wondered if you both could maybe speak to the idea of how much about subcrestal placement and so-called biologic width around implants, as Linkevicius, Araujo, lots of people have kind of been going down this line in the last 10 years especially. And is it that all the time what we thought was better implant design was really that we had more soft tissue thickness because these implants were being put in more subcrestal, maybe deeper? Do you think that plays a role in why we have better bone maintenance? Or is it the implant design?
Yes. To be honest, I think the most interesting study for me, not from implants, but from perio and pros, is from Gianfranco Carnevale at that time in Bologna. It's the best study, I think, in perio-pros with DeFebo, the prostodontist, where what they did at that time, and I learned in a prosto residency program, allow me a little bit to elaborate that. They opened the flap on teeth. They cleaned the periodontal defects, and then they prepared the teeth to the bone level. Then they took an impression with open flap, and then the technicians in Italy, very good technicians, they did the margin of the restoration, which was gold made, 1 to 2 millimeters supracrestal. So the restorative dentist had the provisionalization of the same day, and after a couple of weeks, they had the final restoration. So the biological width was created based on the bone level. So in implants, if you translate this concept, and knowing that from perio-pros, from Carnevale, I really see over more than 20 years, and I show today, that if you place the implant subcrestally and you don't have a butt joint connection, but you have a more tapered connection where we have the bacteria sealing and the bacteria do not go there and the soft tissue is gone, it's on the top, then you have the possibility with narrow abutment to create an emergence profile which is aesthetically and biologically acceptable.
Dr. Stanford, what are your thoughts on, is it the subcrestal placement? Is it the abutment design and the tightness of the connection? Or is it all the above? Or how much of it is the soft tissue thickness that, as Linkevicius would say, it doesn't matter? He would say with platform shifting, he showed in a couple of studies that it didn't seem to matter even with the platform shift and a great abutment or a supracrestal placement of the implant. If the tissue was thin, he still had bone loss. So is this biologic width concept something we should be paying attention to? Or is it more about the placement, the abutment? What are your thoughts?
The objective, I think, is really the easy answer is it's all depends and it's all the above. But I think when we're talking about the thickness of the keratinized tissue and the band, the width, people talk about, but it's also thickness. And the third part of that is there a mucosal pull? Is there a frenum attachment? And I'm thinking of the anterior 6. Is there a is the vestibule going to be laying down where it's going to be tugging on and displaced? Even if you get a band of keratinized tissue that looks great, if it keeps getting displaced, you're creating a disruption that it continuously occurs. So yes, it's what I was going to ask George about is, you show a particular implant platform that you could countersink, and it had kind of a theoretical offset because it was a very thin tulip-shaped abutment. But how does that manage on a prefabricated abutment for an anterior, highly aesthetic, single-tooth implant when you're going to run into the nasal floor in terms of placement? I mean,
it depends how much bone you have from the nasal floor, certainly, or you place a shorter implants in order to avoid. These are, of course, limited cases, when you have to be honest. But I don't want to be in the extreme cases. But the concept I use, I don't go very deep, 2 millimeters, bone subcrestally, as I mentioned today in the panel, from the buccal bone, 1 to 2 millimeters up, mesodistally, of course, deeper. But as you point out, very important aspect, and I think in my presentation we discussed a little bit about that, and you too as well, the technicians create a kind of design, and we clinicians, not very often we see what they create, because they create the abutment, and then on the top they cement or they glue the restoration, they do a screw in, screw retain prosthesis. And the problem is not what you see, but the bacteria recognize this platform or the neck. I say the tulip, and you said also the same thing. Yeah. And I have shown today different implant designs with and without platform. I showed Zimmer cases, I showed 3i cases, etc., where I select the narrow abutment on the top, but also I have to modify also the color of the abutment if there is no in the catalog. I see, for instance, it's crazy sometimes, without to mention names of manufacturers. You open the catalogs from different implant designs, and you have stock abutments which are super over-dimensional, which cannot fit in the human dentition. So having the opposite direction, I go for narrow, I know for every patient the height of the implant, of the abutment, and the neck. For every patient, you need angulated abutment or straight abutment. This is the only option I have. But I try to have a 6 millimeter, it depends, 5, 6, it depends on the manufacturer. If the abutment is too high because there is no interocclusal adjustment, I cut it down. But I never touch the margin of the abutment. And the margin of the abutment, you saw that in the most cases, is like Carnevale's concept, feather type. So we compared 3i independent names of companies, abutments with platform and abutments with feather type preparation technique, which you have the possibility to have the emergence profile. And we found out underneath the platform, there is always plaque. And to point out what you said, I totally agree with you, Clark, on the statement, the vestibule is so important. You bring a very important point because patients, the toothbrush cannot go there. The patients have tension from the muscular attachment. And we have to consider that the vestibule plays an important role in the human dentition. Coming back to the monkeys as a summary, the monkeys cannot brush the teeth and the monkeys live in the jungle. But if you look in the posterior mandible and the maxilla, they have a huge, deep vestibule. And they put the fingers and they can clean the mouth easily, or there is self-cleaning effect. Yeah,
but they are vegetarian, by the way. So
yes.
Just
So you're mentioning though, or the idea though, of choosing this abutment from the beginning,
correct,
and placing this abutment and never removing the abutment. Correct?
Yes.
So a couple of things I want to maybe unpack on some challenges that I could see with that, because from both the standpoint of you are saying that you can anticipate the amount of bone resorption that you will have.
If you open a flap,
correct. Yeah. Well, but even in a non-flap situation, in an immediate implant placement, we know that you have a significant amount of scalloping of the bone in a proximal. And as you said, you could be 4 or 5 millimeters, potentially subcrestal. So does that get us in trouble sometimes prosthetically? Could that get us in trouble prosthetically where we could be challenged, or the technician could be challenged?
Absolutely. It depends how much is the length of the neck. If the neck is 1 millimeter, and we show today the neck of the abutment is 1 millimeter, 2 millimeters, and you have placed the implant deeper, you're done. You have biological problem, and then you have bone resorption. And we see so much perimplantitis across the world, and maybe the reason is because of that. But the bone disappears because the bacteria are there, and also due to the remodeling. So placing an implant subcrestally 1 to 2 millimeters, I go and I have a neck of the abutment, which is at least 3 millimeters. Sometimes, depending on the company, of course, it goes 4, 4.5, 5 millimeters, etc. But the interesting thing is, if you look over a period of time, and I show today, and I can provide anytime the data, you see that the bone on the same in the same mouth, on the same patient, goes away, resorbs, if someone comes and removes the abutment and takes an impression, and independent implant design and implant abutment connection. I have cases where other people thought, oh, he placed the abutments, they were not the final abutments. So they took away the provisional restoration of the final prosthesis, they remove the abutments, and then the bone collapses.
And how much of that, though, is because you're pretty radically countersinking the implants? So you are changing, when someone takes out that prefabricated abutment, you're disrupting a much deeper
correct
environment.
That's why I don't want it.
Than a standard if you will,
But I
bone-level
agree
implant.
with Dr. Stanford completely. If someone places the implant epicrestally, and we have cases, you know, and me too, in everybody in academia, when we have to deal with residents, the procedures occur long, and they take photographs. And anytime you have an open flap for 2-3 hours and takes photos, the bone resorbs. We know that. So all of us, we have this experience. Dependent on the operation, surgical technique you use, and of course, soft tissue biotype, phenotype, how deep you are, how is the bone, I prefer to be always, and this is my concept if you want to summarize from my perspective, an implant must have contact with the cancellous bone. That's why I came to this, no crestal bone. If you have contact with the crestal bone, the bone collapses. So that's why I go more for narrow implants if possible, 3.5, 4, 4.1, it depends on the system, subcrestal replacement, and then one abutment concept.
So why, Dr. Stanford, you mentioned, if it's not as deeply placed, that potentially the disconnections of the abutment might not disrupt the environment as much. So why not take the approach of place an implant 1 millimeter subcrestal as an example and have a disconnection or two if needed. So we give a little bit more option if we do have soft tissue changes. If we do have, what do you think about that versus going deeper?
Well, it's you don't want them too shallow. And personally, I don't want them too deep because now I'm going to be relying on that abutment to maintain the bone. Now in principle, the deeper it is, it's going to have a thicker facial plate by the shape of most. And I'm thinking of the anterior 6. The challenge can be in the anterior aesthetic zone. The 3-dimensional implant placement is absolutely critical in terms of thinking through all 3 dimensions. That's where sometimes with residents, they're thinking buccolingually and they're doing it fine, and then they forget what preserves the bone on both sides of a single tooth implant is the adjacent teeth.
Yes.
So if you're compromising the position of the implant too close to the PDL of the adjacent natural teeth, that's going to change and remodel as a part of the remodeling around the implant, but you're compromising the health of the adjacent natural teeth. That's my only concern about deeply placing a single tooth implant like in a central incisor. Then you got a relatively narrow abutment, and then the technician's got to make an 8 to 9 millimeter wide crown emerging off. So no offense, it looks like a pogo stick. No. And how for a single tooth, that's my concern.
I don't see it as a concern because I have tried and I showed a couple of cases today where I asked always technicians, clinicians, do you prefer the narrow abutment with narrow neck or the same neck and wider abutment? And everybody said, I prefer, especially technicians, narrow abutment in order to have space to create the emergence profile. But I see a big challenge somewhere else, and you didn't mention at all. Anterior maxilla, anterior mandible, or anywhere where people go today and they grind the bone. I think this is the most dramatic thing. And you see so many things what occurred in practices. People go and remove bone, you know what I mean, bone reduction, I mean.
Sure.
And I showed today the outcome which we had with 2 different connections, implant abutment connections, place the implants epicrestally after grinding, And this implant, 70% versus 11% epicrestally placed, they had bone loss 2 millimeters.
But you've also removed the cortical plate. So you're expecting the cortical plate to reform.
Correct.
And you essentially just have cancellous bone that's exposed. So unless you actually did a membrane and did a modified GPR, you need time for that cortical bone to reform.
Remodeling is remodeling, but this remodeling occurs because, as you said, the cortical bone is gone. And this happens today. People remove the alveolar ridge. We don't have vestibule. We have all of this all on XYZ system concepts, We have hybrid restorations, we publish articles on this. With meta-analysis in International Journal of Prosthodontics 2 years ago, which show that if you have metal or ceramic restorations compared to acrylic restorations, we have less failures, less perimplantitis. And I think we have responsibility on this from the AO standpoint to give a message to our patients, to the practitioners, to think more biologically, not to grind the bone.
I guess I'm really just kind of listening to this. I'm concerned about how easy this makes it for the average clinician. I mean, the immediacy of implant therapy and how quickly we're doing it. Teeth are coming out, implants are going in. From a healed ridge standpoint, I think that this concept is solid. I think it's proven. I think it works very well. I think it offsets for biology that we've lost, vertical dimension, horizontal dimension. I think, being that the average soft tissue thickness of most individuals is approaching 2.5 to 2.2, if we're sinking it deeper. Here, And, but where I see this being an issue and my practice is in the anterior implants. I think that the emergence profile and managing, I've come full circle in 20 years from the lollipop look, and this coming up and then out, and then versus like this convex approach where we have the time and the running room to develop the soft tissue and the amount of time we take to develop that. I just see the ease of this. Not for posteriors, it's fine, right? I think in the right situation. For anteriors, I'm having a hard time getting there.
Is it difficult to teach this technique? I think maybe is a good question to ask with that, because I could see that it could be potentially more challenging as you're talking about respecting the mesial and distal bone, respecting the facial and then also committing oneself to this is my abutment and I'm going to stick with it.
So I don't want to mention names, but a couple of years ago, when I was preparing the paper I published in the International Journal of Periorestorative Dentistry in 2015, I took the chief technicians from our school at Stony Brook and I explained to them my concept. We spent 3 to 4 hours that they understand the concept. And they said, and you saw the graphics today, and graphic designers, and they said, Dr. Romanos is an amazing concept. Okay, technicians. When the paper was published, I received 2 amazing comments in writing from a dean of a dental school, very famous school in the country, who he was periodontist, or he's periodontist.
Thank you. Okay, you're good.
Not Dr. Stanford. and another periodontist, and they said to me, this is amazing. The dean wrote to me, this concept should be published 15 to 20 years before. So we go and we learn what? Today I showed, the first slide in my presentation was that 2012, we were talking about crestal bone loss and perimplantitis. In 2022, we show exactly the same thing. The problem is still there. But why don't have crestal bone loss? I don't know. Very rarely. And this happens. If you tell me, you have an implant, let's say, which you believe, independent manufacturer, and you don't have bone loss. Can you create bone loss? Yes. I remove the abutment.
Yeah.
And I take the impression, But it's a lot important. The soft tissue plays an important role. But remember the time, if you don't mind, from the 90s, 2000, when we had implant systems with big platforms, independent manufacturer. And the prosthodontists, they start doing provisionalization multiple times, realigning the provisions in order to create emergence profile. You remember these times? And then they said, now let's go to the periodontist. And the periodontist did multiple connective tissue grafts. There are so many people in the podium who came after 10 years and they said, what I showed to you doesn't work anymore. The problem was the same. And who suffers? The patient. I don't need connective tissue grafts for these cases if I have a relatively narrow platform, means narrow implant design, not very narrow, of course, and I create this kind of tulip. And you showed in a case where you said very nicely, Clark, openly speaking, when you had from the technician the abutment, he said, my gosh, will maybe break or it's not aesthetic, and you start teaching the technician. I really think we need to teach the technicians to think more biologically.
I would agree with that. I think the biological implications of our prosthetics are just as important as the implant interface itself.
Well, and I think as our implants in general, we're seeing more bone level and subcrestal placement throughout a lot of systems, not just one or two.
No.
The connection becomes very important, I feel, more important. And I just maybe as we kind of close out, I want both of you to weigh in on that, because it's what you're proposing with your way of doing that. I believe it requires a special type of connection. I don't. Do you think that's true, or do you think that you can use an internal hex connection, for instance, and place it 2 millimeter subcrestal and have it be successful?
And I have published this specific cases. The only problem is when you place an implant 1, 2, 3 millimeters subcrestal, because the concavity is never there. The ridge is never flat. You have concavities. Let's say you have 2 to 3 millimeters in one area, epicrest in some other areas, and you don't need to graft, all right? But you place on the top, you have external hex or internal hex. The problem I have is to engage the abutment. If there is no emergence profile, maybe I have to do countersinking, and then I remove the bone. But the bone goes over the platform. If you don't remove the abutment, you have 5 years follow-ups.
Dr. Stanford, you feel the same way about that? That placing an internal hex connection implant, 2 or 3 millimeter subcrestal, would you feel good about the stability of that?
It can, as long as it's some form of a conical interface.
Well, see, that's what I was kind of wondering how you felt about that.
Well, like we're basically an X hex turned inside out, though. That could be an internal hex without a conical interface.
As long as there's a cone component, it doesn't have to be very much.
We like that both of us the conical connection. It's not discussion.
Well, that's what we're saying is because when we say internal connection, that could mean a lot of different things.
We're trying to define it a little bit more.
No. That's why I make the clear statement. I agree. We prefer, both of us, conical implant abutment interfaces. Yes. But I have seen that if you tie the abutment in an area which is cylindrical, butt joint, there is no necessarily bone loss in every case. In our study, what I showed, conical versus butt joint connection, we lost the 2 millimeters in the butt joint connection, and we have more bacteria. But what happened? I grind the bone. If I wouldn't grind the bone, it would be a different story.
Okay, because that's what I was sort of referencing, is it looked like, and we've seen other studies that have seemed to show that internal connection, regardless of disconnection, seems to be because we see more micro movement could potentially, but you're saying that's more about the grinding of the bone versus the difference in the connection.
Correct, because the implants were connected, splinted together, and there is no micro movement in this study. Very good points you bring up. But the thing is, we need to go back and to see the details we did in these studies. And the implants were not subcrestally placed. But if I would place the implant subcrestally, I would decompensate or compensate this remodeling of 2 millimeters.
I want to ask this final question as we kind of finish up here. What would you say that the average thickness after a case is finished of soft tissue above the interface is in one of your cases? Let's say the average
over
thickness,
the platform?
No, just from the platform up, what would be the average thickness that you're shooting for?
I would say 2 to 3 millimeters.
Okay, so we know that Tomas has published multiple times with different connections that if we set and say that we want a minimum of 3 millimeters, no matter what, that it'll help to preserve bone. And that's with disconnects, not just a single abutment one time. Yeah. So is it more about the volume of soft tissue in the blood supply that you're providing for the support of the abutment, the restoration, the implant interface? Really, actually, it's for the bone right there that we removed because there's remodeling happening at the cortex, right, and in the medullary bone there, if that's exposed. Is it more about that we've given enough blood supply, the ability of soft tissue to form that 3 millimeter call, per se, versus the one abutment, one time concept?
Yeah, which is more important?
Which is more important?
Yeah.
Okay, I have done multiple cases and because I'm the surgeon, okay, dehiscences, vertical grafting, posterior maxilla, posterior mandible especially. I go more and more to the posterior mandible, which is the most complicated if you want. And after grafting, you have some kind of resorption potentially, and you place the implant subcrestally, and you have some dehiscencies. I regraft again. Over a period of time, without remove the abutment, the tissue is the same, and the bone is the same. And this is what I showed today, 16 years follow-up, 19 years follow-up in the CBCT after grafting.
You just have to follow where the freedom pulls are occurring.
Yes,
100%.
always.
A lot of people don't,
well,
especially in the mandible, people don't look for that. And
I think that what you're saying there
Absolutely.
came up twice now, and let's talk about. I mean, we could go on forever here.
It's very important topic.
Yeah, it's very important because Pat Allen speaks about non-movable tissue. In fact, he likes to even recategorize what periodontists have been saying, which is we want dense, bound down soft tissue around our implants, bound down, non-movable. And I think, again, that is so important around teeth as well as implants. You know, teeth can survive better, but implants, it's impeccable.
So if you compare my philosophy, if I can say that, compared to the philosophies of people who grind the bone, I reconstruct the alveolar ridge. This is what differentiates me with others. So I prefer to have alveolar ridge augmentation. Of course, you need to have the training, the experience to stabilize my membranes. All of my membranes stabilize with tacks. The particles there don't move around like crazy. And then I have the vestibule. Absolutely. Yeah. But if you go and you remove the bone and you place the implants apically and you damage the bone,
well, you're going to get a migration of mucogingival junction.
Then you're done.
And you're done. No matter what you do.
Yeah.
So if you have an active frenum, do you phase the removal of that first before you start trying to do it? So it's already stable.
Always.
So vestibuloplasty, which is a thing that very routine. It's not talked about as much as it should be. Even in removable pros, I deal with this a lot with my denture patients. And, you know, these techniques that we should be utilizing for removable pros, we should be utilizing for also for our single unit implant restorations.
No, this is great.
It's a great topic.
Good conversation. And we so appreciate you guys being willing to come and talk with us and kind of take a little bit of a deep dive into the topic and hear kind of some of the concerns that I think people raise when they hear about that. It sounds like, wow, that sounds like difficult, but it's you kind of get it defined what makes it successful. So that's excellent. We thank you guys both for being with us. And
thank you.
If you've gotten something from this, you know, if you're looking and thinking differently a little bit about subcrestal placement, there's some of you out there who still are very anti even thinking about a subcrestally placed implant. I think
Why?
I think times are changing. It's time to embrace that. And so we really appreciate once again the collaboration with the Academy of Osseointegration. Obviously, if you're not here at this meeting, you should be. And there's always next year. So, but thank you very much, Dr. Stanford, Dr. Romanos, for being with us. For Wes, I'm John, and we are the Dental Guys.